So, hi, everyone again, welcome. Welcome to the Meet the Expert Q&A session. Today's topic is photobiomodulation and pain management. With the Fotona lasers, of course. We have with us Sasha Terlit, Head of Dental Program at Fotona. We have Dr. Neja Korun, Head of Gynecology Program at Fotona, and myself, Laha Master in Laser Dentistry Manager. But most importantly, we have here with us our experienced Fotona laser users. They're both Lightworker dental laser users, Bachelors of Dental Science, Masters of Science in Laser Dentistry, as well as Laha Master's Program graduates. Dr. Lin Nguyen is here with us from Canberra, Australia, and Dr. Jason Pang from Sydney, Australia. They are both well aware of the benefits of photobiomodulation, and they both incorporate PBM probably on a daily basis. There's definitely a huge potential for PBM in dentistry, but also in aesthetics, in dermatology, surgery, gynecology. So I'd like to thank all of those who already sent questions in advance. We'll make sure to answer them. And for everyone else, I'd like to remind you that please post your questions in the Q&A box, Q&A button at the bottom. And at the beginning, I would just maybe like to give some basic information to everyone which have Fotona systems or thinking about getting Fotona system. We have a new line of Marco handpieces, which are the perfect of handpieces to be used for photobiomodulation and pain management. In aesthetics and dermatology, you can do PBM with SP Dynamis or Time Walker 4D. In gynecology, for example, we have Time Walker Intima Laser. And of course, in dental, we have Lightworker as well as SkyPulse. And now I would like to give my word to Sasha for the questions.
Hi to everyone. Thank you, Spela, for the word. So to stick with evolution of Fotona technology, and you have mentioned already Marco, the new line of Marco handpieces. So we have different dimensions, different sizes with 10, 24, and 43 millimeters in diameters. So S, M, and L. And I would like to ask you first, Dr. Pang. So from a dentist point of view, which are your favorite dental indications for each of those new handpieces?
Okay. Well, thank you, Sasha. Thank you, Spela, for asking us on. For the smallest of the handpieces, so the size, the small, which is equivalent to the Genova handpiece that we used to use previously, those we tend to use for very specific spots around the mouth. So something small like an ulcer, or if we're trying to say target something like an implant or something like that. So anything that's smaller, or if we need the LA adapter to get the 90-degree, the right angle, that's where we would use that handpiece. The medium tends to be really quite versatile. The medium, I'm able to do the majority of the tongue, half the palate in one go, and then I can do, for instance, cover the whole TMJ usually with one or two applications. But for anything extraoral, definitely the large is what I use. So any treatment of oral mucositis, if I'm treating the cheek, if I'm doing radiation dermatitis around the neck, if I'm doing painful things around the neck or any sort of facial injuries, then certainly we would use the L. So yeah, that kind of just basically gives a sort of a broad overview of how we use those different handpieces.
Thank you. We will come back to specific indications that you already mentioned, but now, apart from dentistry, there is a huge potential for PBM also in other fields in medicine. And Dr. Nguyen, what are your favorite indications for PBM outside the oral cavity?
As the oral cavity, in terms of still related to dentistry, and oral cavity is the head and neck pain, the shoulder, the trapezius, the splenius capitis, very deep muscle, that perhaps the penetration of Genova can't get it there, but which larger spot size, collimated beam, we definitely can get in depth, and also not just the width that we can cover more, is also the depth penetration can go further. So that's catering for our day-to-day TMD, because not just stop. Back in old day, we often think TMD is pretty much just a TMJ, but it is actually not. It's the disorder of cervical spine or the muscle attached to it, so the upper back. And so that it helps us to speed up, the treatment time and also more efficient. And so that's the large marker. With the outside of dentistry, because to be clear, I'm a dentist, but I'm also a laser therapist. Our business got two streams of business. One is purely dentistry, and the other one purely aesthetics. So beyond that, I have seen a very, very good result with cases where patients have ongoing joint problem, particularly those that have ailment with their joint replacement got nowhere. And we know the joint replacement like hip and knees and so not so much hip, I don't think to hear much, but knees and ankle replacement, often you hear people having complication rehab, months and months, didn't get very far, or they stuck at one point. And I find that those are the marker L is the one that basically rescue them, get them to the level where they'll be mobile again, they'll be able to do the exercise again, get back on their track of rehab again. So I think that's the most wonderful, effective result I've seen so far. That is, apart from the muscles, but a lot of times it's a joint problem. And beyond that would be also, yes, it's for aesthetics, because you would have patients this day demanding for, let's say, injectables, but they are having blood thinner because of cardiovascular complication. And so you can confidently inject. And then if they have bruises, you get on with it right away there and then, and within the next 2 day, consecutive day, you continue PBM, the bruise settle very, very quickly. So a patient don't have that long downtime. I find downtime only at most about 2 or 3 days if you get on with it right away. And so in terms of aesthetic, it's got a lot of applications there. And, I find, I just discussed then a really interesting case, very early, very new, is a lady with CMT, Charcot-Marie tooth disease. A disease, if you looked up, is very famous, the Lee family of Samsung family in Korean. That's genetic inherited disease. And then basically slowly you lose the muscle, the motor neuron or the sensory of your extremity, hand and feet, and they become slowly disabled. And we got this lady coming in through her niece who requested us to see if we can help. Because her niece is an aesthetic client of ours. And we started, and very interesting, after 2 days, about 3 days apart, 3 days all up, she started to feel the muscles in her hand, we was contracting, start to feel easier. And then she started to, by the time we did the 8th session, she just said she gained some sensation on her hands. When we marked the spot with our white marker, she said, hang on, this is the first time in a long time I actually can feel you touching my hand with, with this marker here. So that was just an amazing, feedback. And for a patient, that gives them some hope. I mean, that we don't want to lead people to, we don't know where to go, to be honest, but at least it's something there's a way to think of. And so photobiomodulation is one of those things I often say to patients. It cannot cause harm. If your cells already at the optimal level, it won't need to absorb the extra energy anymore. The mitochondria don't need anymore. But if the cells is suboptimal, that's when it absorbs. So photobiomodulation, especially with handpiece like a marker with a collimated beam, safe, and we have less worry about the skin, then it is, so it helps people a lot beyond what we can imagine. And that's the worst scenario, it doesn't work if that body, that cell doesn't need it. And in my experience, if it's after 2 sessions, if the patient don't have any response, I don't feel it's something else, you misdiagnose or something else going on, that we need to get back into the beginning, sort out the problem, what causing it. But it is so good that after one, even just one, but often at most, so 2, if patients have no, and they have 1 or 2 like that, and we sort of say, maybe this is not for you, and we got the wrong understanding of what causing the problem in the first place. And so go back to medical investigation again.
Thank you, Lynn. We will talk about protocols for specific indications more in depth lately after the first session. But so quite a broad list of indications. We started with dental indications. Now out of the oral cavity, also in static, but there is also potential for PBM in gynecology. So Neja, can you comment a little bit more on that?
Yeah, this in fact is a new field, I agree. We've had a look over the field, and we found actually 2 important indications that could be that could respond very well to PBM. One is in fact episiotomy wound immediately after the partum. Another one, which is, I think, very important one, are cracked nipples due to breastfeeding that could really benefit from this PBM. But not only because of this wound healing, but also the analgesic effect of the PBM. So these are, with these PBM settings, something we called cold PLLT treatments. On the other hand, we have warm PLLT, for example, for pain management. With our old handpieces, we did a study on vulvodynia. This is superficial dyspareunia, and patient responded really well. So if we used, for example, the Marco M with the settings that are equivalent, I think we could get pretty much the same results and really a relief for patients who are suffering from this, this indication. So these are just general, something that needs to be work on, but there is a huge potential there.
Thank you, Neja. So now we'll go back to the dental applications. You send us quite some questions that we need to address, and we will start with the first one. So which protocol you use in prestige of inferior dental nerve and the time intervals for the treatment?
I probably would do the protocol, and then Jason might add on the theory side of things. With inferior dental nerve canal injury, and often it tends to occur either during surgical removal of the wisdom teeth, and now with implants is more and more widely available, offered through the work of the general practitioner. We can also see amongst would be the risk of injury, and that I've experienced first-hand cases with that. Was the protocols for the moment the patient 5-6 hours later or the next day telling you that they haven't regained their, then the sense of the sensory, it's filling of the lips or tongue. The first and foremost important is we must go remove that implant, unwind it out, give the patient steroid, and in my case, I definitely would do the PBM right away, because the compression of the implant onto the inferior dental nerve canal, that's caused the injury, and as the injury, there's also increase in blood supply, and that port of blood are actually added to the pressure unnecessary impinge on that nerve. And so time is very, very critical. And on top of that, the steroid helped to reduce, significantly reduce the inflammation and hope to reverse the injury. So we add the PBM to it so that we favor the lymphatic drainage to reduce blood pressure buildup, as well promote healing for both the nerve, heart, and soft tissues. In this case, our experience where I report in there was the lady had by the time she saw me, that had been nearly 3 weeks on with an implant still in place. She had contacted her dentist multiple times, happened to be a colleague I know really well. And he would just basically say, it will go away, it will go away, which to my surprise, any of us hear the next day the patient ring with a numb lip, we run, but this is ignored for 3 weeks. So by the time she came to me, there's intraoral swelling next to the implant, rock hard lump around the mental foramen, intraorally and outside on extraoral tissues. And then on the lip was a burning sensation. And so she got the whole thing as paresthesia now. And so with the PBM, what we do then, let's say that because the protocol there is to reduce the pressure and inflammation to try to rescue the nerve. And so we basically try to put the de novo intraorally where we can get to. She couldn't open very well. On top of all the stress and pain, she also got muscular spasm due to all of this clenching on top of it. So intraorally, we use local de novo to, at the time, or Marco S now, would be locally on the swelling area, on the internal mucosal surface of the lip. And on the outside, then we would basically tracing from the mental foramen nerve on the lip on this portion. And also you can do extraorally now with the Marco. It'd be wonderful because the depth of penetration we can get to inferior dental nerve canal as well to some extent. And so that's what we do. And also we don't forget that we also need, before we start all of this, our protocol work, actually we start with the lymph node, the submandibular and submental lymph node that you need to open it first, open the gate so that we can let all of these fluid we want to release will go, and then intraoral and then extraoral. And on top of that, we also added to help to PBM and relax the muscle of mastication, which giving her also a lot of problem. The frequency, in that case, I do it every day. We saw her consecutively for 3 weeks straight. As much as we can, the first week was every day, and it was slowed down to pretty much once every second day. And in the PBM, we've got to remember in this case, because it's a small area of injury, so you can do it once a day without problem. If we do a big body part, of the body, or patient who's in chronic pain with lots of muscular spasm, a lot of toxins being trapped in the muscles, and if the patient have compromised medical history, we need to slow down initially. We only do it once every second day, because the moment you put the PBM on, you open the gate, the toxin go. And I have seen it through my experience with treating patient with TMD through various forms to relax the muscle. The patient can respond by actually they can faint, they can feel nauseous, they can go and cry uncontrollably for half an hour, because all the toxins being released. So that's the protocol. For the mouth, it's not too much of a problem in a case like that. And I'll try to basically get help. At the same time, we try to also add on top would be, perhaps if you've got your hand or no training on steroid, you can inject steroid to the area as well. But in this case, she had enough for all of that. So just PBM alone, but pretty much the next day, she looked different. She recovered, she looked well, better. And so that would be our, the main thing in there was we try to release the pressure and get this healing going, get lymphatic drainage happening, and PBM is the perfect tools for that.
Thank you. So continuing with the next question, maybe for you.
Actually, if I could continue on with that question, because
okay,
there are some papers on that, and just to let you know my experience as well, I would do very much the same protocol as Dr. Nguyen. I would treat them every day if possible, or as much as they could come in. I would use the Marco L handpiece, certainly on the lymph nodes first, and then following the inferior alveolar nerve, usually from mesial to distal. If possible, I would try and use the medium handpiece to try and maximize the penetration depth intraorally if possible, but if not, then I would use the LA adapter or just with the small handpiece to try and target the nerve itself. If I can just share the screen as well, what I might do is just show you some of the articles that are relate to nerve injuries and what the current recommendations are. So the current recommendation is if it is a neuropraxia, so if it's compression of the nerve itself, or if it's axonomesis, which is sort of damage to the actual nerve, but the myelin sheath is still intact, then that is a good indication to use for PBM. So the understanding currently is that it is dysregulation of ATP production and the neuronal depolarization. So if you are able to maximize the ATP production within the nerve itself, then you can have healing, you can have organization of the myelin sheath, you have improved function, improved pain reduction, decrease of inflammation, and so on. So it will essentially just heal up more quickly. And also you need to be able to start the treatment as soon as possible, because the understanding again is that as soon as you start to do the treatment, you're going to have less compression of the nerve and better chance for the nerve to heal.
So actually, according to your protocol for complex cases that you irradiate each day, you said, right? You haven't observed any so-called overtreatment effect in terms of frequency. So because in the literature, there are many different protocols how to treat especially heart conditions. So you treat every day.
Yep, so like I
In
said,
my case,
issue having any problem. It's just the lies that the toxins release and can make the patients unwell. That's from my end of things. We treat chronic pain.
Yes, so in the same way that like Lynn said, if it's a small injury, it's something that typically can be treated more frequently. In this case, say it's an acute injury, yes, you absolutely would try and do it every day. If it was something, say it was damage that occurred several years ago, then there would be probably not a lot of advantage in treating it every day. You might consider doing it 2 or maybe 3 times a week. From a practical point of view, someone that has a recent injury, they're quite motivated to come in daily, but someone that's had a chronic injury for a long time, reasonable is 2 or 3 times a week that they can come in. So in general, acute is treated daily if possible, and if it's chronic, then 2 or 3 times a week. And can you see this paper? Is this shared with you as well, this diagram?
Yeah.
So in this one, it basically, as I said, it's a mitochondrial dysfunction. So you're trying to, again, heal. And this one was studied using 810 nanometers, of course, with the ND-YAG, that's 1064. 810 tends to be the most studied wavelength. And there are differences between the 810 and the 1064. So it may be possible with further study to use them both at the same time because of slightly different mechanisms. But certainly we have used combination therapy for certain patients and achieved quite good success. But if you have a look at their treatments, it's quite different to how we use it with a flat top collimated handpiece. So you have to keep that in mind as well. We are typically using around about 0.2 to 0.5 watts per square centimeter. These even though they're quite similar in their output there, that's actually using a Gaussian handpiece. So the advantages certainly of the flat top and collimated handpiece is that it just makes it so much simpler. There is a procedure called the stamping procedure where you can just do one spot at a time, and you can set the amount of time that you do that for, whether it be 30 seconds or 60 seconds.
Thank you. Yeah.
Sorry, if I may, there seems to be a lot of questions on the parameters. We have different parameters. There are one for photobiomodulation, or let's say low-level light therapy. And then there are the parameters which cause heating, which we use primarily for, let's say, pain reduction. So from your side of view, Jason or Lynn, what are you using, or what kind of parameters are you usually using?
Jason, you go first.
So for myself, because I mean, we started with the Genova, and we had really good results using half a watt per square centimeter. So for us, we translated that quite well into the larger handpieces. So my preference was for pure photobiomodulation in terms of healing, to use around the 0.5 watt. But what I would recommend is just to follow the Fotona established protocols for now, until you're a little bit more experienced. So the main difference is that in something like the Marco L, instead of 0.5, you are using, is it 0.2? Is that right?
Yeah.
So in that case, you have to be mindful that you are not trying to heat up the tissues, because if you heat up the tissues, you can cause increased inflammation within those structures, and you may have reduced healing. So in the same way that you might say have heat shock proteins and so on formed, you can have that happen and decrease the healing. My own preference, though, is that if we do not get sufficient pain reduction, and it's nice to talk about photobiomodulation, but it's something that's sometimes difficult to measure at the time. But pain reduction is something that you can see almost immediately. So we often will start with a lower setting, and if we get good pain relief with that lower setting, we'll just keep it at that and reduce the pain by a few points. If we don't sufficiently get a good pain reduction, then we might repeat at the same intensity, or we might increase the intensity. And there's a case that I can show you where we used an increased intensity for a dystonia case. And we might talk about that later. All right, thank you, Lynn.
Yeah, it's basically very important to address this difference between photobiomodulation treatment and solely pain reduction treatment, because when you use the parameters for photobiomodulation, this is actually just a photochemical and not photothermal. So there shouldn't be any heating of the target tissue with photobiomodulation. But when you're addressing the problem of pain reduction, you can use higher settings to heat the target tissue, but this is not the photobiomodulation anymore, right, Jason?
Well, technically, I guess it is still photobiomodulation, but you are having, you're always going to have modulation of the tissues itself. It's more if you are leaning towards purely healing or pain relief, because if you are trying to have pain relief, there's always going to be an overlap between pure healing and pain relief. So if you lean more towards one way than the other, then you have to use the appropriate settings. But that doesn't mean that if you have pain relief, you're not going to have healing as well. And we've seen that over using this for years and years. So it really is very safe.
In order to determine heat or PBM or cold, we need to also understand the pain. Is that acute? Is that chronic? Is that neurogenic? Is it acute? Do you want to settle the swelling and the pain? And everyone coming with pain, with different causes of problem. So if it's acute, you don't want any more heat because you're going to increase the volume, the pressure, the patient might not necessarily doing any better. And so you definitely want to do the right PBM, the right setting, just enough to open gate for lymphatic drainage to happen, healing start to go for ATP. In cases of chronic, especially when we've got to do with head and neck, where I deal a lot with, then in terms of those cases, there'll be times where you really have to stir it up. And those who do TMD injection would know that there's a protocol to use Rolo injections. That's kind of less sugar. You inject it into the joint where the muscles, the Sharpie fiber. So you basically want to stir the tissue right up. It's gone crazy. You want to get the inflammation going again, because after a little while, it's not happening. Patient can't heal. And so that is when I see the indication for heat, lots of heat. You just want to drive things a little bit beyond. But then patient can also have, they go home, they can have quite significant discomfort, and they need to be warned for that. And so that, for people having chronic pain, I might consider that, but in my hand, usually most of the time PBM is enough. We don't really have to go to using high heat a lot of time.
And what are your exact parameters for PBM, Lynn?